Good afternoon, everyone, and welcome to the Support Hospital Opioid Use Disorder Treatment, Shout Texas Echo. Please note that we are recording these sessions for later distribution. Please note that anything listed in the chat will not appear in the recording. My name is Shreya Prasanna, and I will be facilitating today's session. A few quick announcements before we begin. To help us with attendance, please enter your name, email, and affiliation into the chat function. To access the chat feature, please click on the speech bubble icon on the bottom of your Zoom window. To all the BeWell Texas providers, please make sure that you identify yourselves during this session. If you are joining via phone, please email your phone number and name to bewelltx@ithska.edu. Some housekeeping. Please stay muted unless you're speaking. If you have joined by computer, please, your mute button is at the bottom left of your Zoom controls. If you are on the phone, just press *6. We also encourage you to unmute and speak, especially during the discussion portion of the session. We want to hear from as many of you as possible, so please keep your comments brief to allow time for others to speak up. Please note that no protected health information is allowed in either the chat or the discussion. If you would like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. Towards the end of the session, the Shout Texas team will send a link to an evaluation survey. All participants filling out this survey will be automatically entered into a raffle for a $30 Walmart gift card. Our didactic today is on medication for opioid use disorder in the emergency department, why, when, and how, and will be presented by Dr. Mitch Katona. Following that, we will discuss a case presented by Dr. Anupama Kapadia. We will start with introductions, followed by didactics, BeWell program announcements, case presentation, and open discussion. Thank you all again for joining today's Echo. In the spirit of all teach and all learn, we encourage you all to share your experiences, questions, and insight in today's conversation. And with that, we will do some introductions. Alana.
Hi, good afternoon, everyone. My name is Alana Bolton, and I am the Director of Shout Texas here at Dell Medical School at the University of Texas at Austin. Thank you so much for joining us.
Thank you. Dr. Walker.
Hi, everybody. I'm Blair Walker. Thanks for joining us. I'm with the Hub team at Dell Medical School. I'm with psychiatry.
Thank you so much. Dr. Lindsay.
Hi, everyone. Dr. Lindsay, Director for the Center for Substance Use Training and Telementoring at BeWell. Thanks.
Thank you. Dr. Katona.
Hi, everyone. I'm Mitch Katona. I'm an emergency physician at the Medical Center Austin and the Assistant Clerkship Director for EM at Dell Medical School.
Thank you so much for joining us. Dr. Kapadia.
Hi, everyone. My name is Anu Kapadia, and I'm part of the Addiction Medicine and Healthcare for the Homeless team here at Community Care and also Assistant Professor at Dell Med in Internal Medicine.
Thank you so much for joining us today. With that, we will move on to our didactics. Dr. Katona, you can take it away whenever you're ready.
Thank you. I'll get my screen shared here and we can just jump into it. First of all, thank you, Alana, for inviting me to give this talk. Really excited to get to share the emergency department perspective for medication for opioid use disorder with y'all. Definitely too broad of a topic to cover in 20 minutes, but we'll hit some high points that I think are particularly high yield. I don't have any disclosures. The learning objectives today, I'll focus on some common ED presentations for opioid use disorder, including an emphasis on opioid withdrawal syndrome, to talk about some of the considerations with buprenorphine in particular. Of course, methadone being another very common medication for opioid use disorder, but I would say in my practice and in my partner's practice, buprenorphine is far more commonly used for induction. And so we'll talk about buprenorphine in particular. And then bridge therapy and other components of dispositioning a patient from the emergency department. So I know everyone in this room is very familiar with the tragedy that is the opioid epidemic, but I think it's worth just kind of giving some background and maybe some statistics to the emergency department population. We're in the third wave now of this epidemiologic trend, dominated mostly by synthetic opioids. And with opioid deaths obviously just continuing to climb. I think it's always interesting to think about the morbidity and mortality of conditions that we associate more with emergency medicine, like heart attack and stroke, with the morbidity and mortality seen in opioid use disorder patients. In 2017, the one-year mortality of non-fatal opioid overdoses reached 5.5%, which is comparable to the one-year mortality after an acute MI. And I always think that that's pretty profound, that this patient population certainly has a comparable morbidity and mortality and is worth every bit of the emphasis we place on these other conditions. Also striking me that in 2021, opioid overdose was the most common cause of death in Americans under 50. And on a maybe more optimistic note, for just the second year, 2023 represented a decline in those overdose deaths. So for the first objective, I want to talk about identifying patients with opioid use disorder in the emergency department. So, of course, sometimes that may not be much of a challenge. In rare cases, a patient may self-identify as having opioid use disorder, but that's, of course, very rare. There's tons of stigma that comes with self-identifying, and patients are often afraid or embarrassed or fear that they'll have some adverse change in how they're cared for, sadly, which prevents them from self-identifying. Opioid overdose might be another presentation that would be rather self-evident, that we would see in the emergency department pretty regularly. But these two represent a very, very, very small fraction of the patients that come to the emergency department with opioid use disorder. The ED represents probably, in many cases, the main interface that patients with OUD have with the healthcare system in general. And the population is quite large and far larger than these two smaller groups. I think opioid withdrawal syndrome is another way a patient may present that probably, arguably, I would say represents, the highest yield opportunity to have an emergency department intervention for patients with OUD. These patients are, of course, at some of their lowest points and truly suffering quite tremendously from OWS, opioid withdrawal syndrome. And with that comes a pretty big opportunity for us in the emergency department to establish some rapport and hopefully increase our chances of helping these patients reach a maintenance phase. In the ED, we often will see presentations that are actually reflective of comorbid conditions with OUD rather than OUD itself. We think about acute psychiatric deterioration being often comorbid with opioid use disorder or other substance use disorders. And we think about certain infections, particularly soft tissue infections, spine infections, endocarditis, infections associated with injection drug use. And I think the important thing from our perspective in the ED with these presentations is to have a much more targeted interview, a much lower threshold to inquire about substance use history and opioid use disorder in particular to further identify these patients. Screening is another important consideration, and this kind of maybe takes a step back to a medical director level, but there's certainly things at an individual provider level that we can do to identify more patients with screening methods. We're pulled in a million different directions in the ED. There's obviously so much going on that we can't have, universal and comprehensive screening. But there's plenty of studies in the literature that show that even just a one question screening tool, kind of modeled after a similar one question suicidal ideation screening tool at triage, where when nurses simply asked, in the last week, have you struggled with taking painkillers or taken heroin or fentanyl? That was shown to be as sensitive, if not more sensitive, than other methods of screening, including chart review, with minimal impact to triage time or resource demand in the ED. It's also worth considering targeted screening for certain patient demographics, patients that have maybe a higher prevalence or higher risk from opioid use disorder, such as patients who are pregnant, and targeting screening towards those groups as well. Next, I want to talk about buprenorphine. We'll talk about how buprenorphine is used in the emergency department, and some other considerations related to its use. Again, I think this group is probably largely familiar with some of this pharmacotherapy, so I won't spend a ton of time on it, but just to maybe review, the main advantage of buprenorphine comes from its mechanism as a partial mu agonist with a very high affinity for the mu receptor. Because of this, buprenorphine is well known to decrease all-cause mortality in opioid use disorder. And it has a low abuse potential owing to this partial agonist effect, often described as the ceiling effect, where the euphoria and the respiratory depression associated with full agonist is not generally associated with buprenorphine as a partial agonist. And you can see that ceiling effect kind of dictated in this chart here. It's buprenorphine compounded with naloxone also represents a way of mitigating its risk of abuse. Naloxone has poor bioavailability when buprenorphine is taken as intended as a sublingual or oral dose, but has its mu antagonism properties when used in an inappropriate route such as injection or insufflation. And so this represents a further way that buprenorphine can have a mitigation in its abuse potential. The first two indications here are the ones that I'll emphasize today, as those are really what's more pertinent to the emergency department. Of course, there's a fourth indication for buprenorphine in the form of treatment of pain, but we'll talk about the two relevant to the ED, first treating opioid withdrawal syndrome, and second, establishing a bridge therapy between emergency department disposition and ideally establishment with maintenance therapy from a primary care setting. So opioid withdrawal syndrome is really a very critical diagnosis to be making in the emergency department. The morbidity and mortality for OWS untreated is quite high. These patients, of course, are at great risk of utilizing unsafe opioids, so-called street opioids, if untreated. It's a pure clinical diagnosis, so it's going to be made purely from a detailed history and examination. And we have clinical decision tools like the COWS score, the clinical opioid withdrawal scale, to help us with that, which I'll touch on a bit in a second. Although getting a detailed substance use history is important, it's really not necessarily going to guide your diagnosis or ruling out of this diagnosis. Simply the variability in the half-life of whatever opioid the patient may have been using, or their history of tolerance, is going to make it too difficult to predict OWS strictly from the quantity and time of last use. Once identified, it's very critical that OWS be treated quickly and aggressively. And I think that's worth noting in this new era of emergency medicine where, sometimes after a medical screening examination, patients are waiting hours to have their kind of definitive evaluation. And so having at your shop, having a system where triage providers are well educated on OWS and feel comfortable giving initial treatment for OWS is important to prevent patients from leaving from the waiting room with untreated withdrawal symptoms. Buprenorphine is far superior to adjunctive therapies that a triage provider might provide instead, such as clonidine or ondansetron. And there's really few contraindications to buprenorphine. I think probably the most important one in the ED would be active opioid intoxication, for fear of precipitated withdrawal, although we'll talk about how even precipitated withdrawal can be safely managed in the ED as well. Even though buprenorphine alone is not associated much with respiratory depression, that would represent a relative contraindication as with some kind of motility. But again, very, very few contraindications to be concerned about, fortunately. This is an algorithm for medication for opioid use disorder in the emergency department that my mentor, Dr. Sharon Long, and I developed, that's now in use at Dell Seton Emergency Department and Seton Main Emergency Department. And hopefully we can continue to have this adopted at other departments. I want to use it to, we've kind of talked a little bit about some elements in this algorithm, but I want to use it to talk a little bit specifically about pharmacotherapy for withdrawal, opioid withdrawal syndrome. I mentioned earlier that aggressive treatment with buprenorphine is really important, and that includes making the treatment high dose. And so high dose in this context, we're typically talking about an 8 milligram buprenorphine dose, as opposed to low or more moderate doses of like 2 or 4 milligrams that have not been shown to have the same degree of efficacy as 8 milligrams. High dose buprenorphine has a number needed to treat of 2 for treatment of attention, which is a number needed to treat that you really won't see with a lot of other medications. After that initial dose of 8 milligrams for opioid withdrawal, the next step is to monitor the patient to see the effects of buprenorphine. Obviously, in most cases, and hopefully the patient's symptoms will improve. And at that point, a second 8 milligram dose should be given to complete a loading dose of 16 milligrams. In the event the patient's symptoms don't improve, there's 2 things to have on your radar. One would be potentially that there's something else going on that we're missing that's not just OWS. And so kind of broadening your differential and reevaluating the patient is important. If the patient's symptoms worsen, that may indicate something that we mentioned earlier called precipitated withdrawal. If their mu opioid receptors were bound to some full agonist that was then kicked off the receptor by buprenorphine, they may have an abrupt decrease in their effective mu agonism. Fortunately, this can be addressed by simply giving additional buprenorphine. Specifically, the patient can get further doses of 8 milligrams of buprenorphine, again, sublingual every 1 to 2 hours as needed to control precipitated withdrawal symptoms, up to a recommended maximum total dose of 32 milligrams. And then that'll kind of take us into bridge therapy that I'll talk about next. But just to kind of finish this last point, I wanted to talk about a few special considerations. So number one, there's plenty of literature that even if the patient does not require or does not have an indication in the ED for buprenorphine acutely, home initiation of buprenorphine is completely appropriate and can be kind of part of the bridge therapy that you prescribe. The key thing here is simply to be very detailed in your education with the patient, that they don't initiate at home too early, because then they can, of course, precipitate withdrawal, and that can kind of be a substantial negative impression that they can have of buprenorphine thereafter. Also relevant is with pregnancy. So buprenorphine very safe in pregnancy. ACOG certainly backs buprenorphine for treatment of opioid use disorder. It's improves outcomes both for mother and baby with decreased rates of neonatal abstinence syndrome in patients on buprenorphine. It's also minimally absorbed into the breast milk, and so there's no need to have any change in how it's used in patients that are breastfeeding. Okay, so I'm going to bring it home with bridge therapy and sort of some other considerations and goals to have for your patient at the time of disposition. And I'll come back to that algorithm in a second to help us with that. But bridge therapy is really a very critical part of how we care for these patients. Although our goal is to have a direct referral to an outpatient treatment program at the time of discharge, preventing relapse is absolutely going to include having a buprenorphine prescription to last them through to that appointment. The big boon that we have in our specialty was the removal of the X waiver a little over a year ago. There's now no additional requirement, frankly, for a prescriber beyond Schedule III authority through their DEA registration. And while there used to be a cap on the number of prescriptions that a prescriber could dispense, that cap's been removed as well. It's thought that based on expectations on increased prescribing, that some 30,000 additional prescriptions, or sorry, additional patients in maintenance phase will be reached annually with this change. Okay, and then the other thing I would say is, just as we want to be aggressive with the dosing of buprenorphine, it's also appropriate to be a little bit liberal with the duration of the bridge therapy. So again, hopefully these patients are receiving a direct referral within a couple of days to an outpatient program. But I think it's completely appropriate to extend that bridge therapy to include several extra doses or days of treatments to ensure that they don't have any gap in their treatment that is extremely high risk for relapse due to cravings and withdrawal symptoms developing. Okay, so beyond bridge therapy, there's plenty else that we need to make sure patients have at the time that we discharge them. We talked about having good control over any opioid withdrawal syndrome symptoms. One thing I haven't touched on really is harm reduction. And I think the most important component of that, at least from the emergency department, is naloxone. So all of these patients should receive a prescription for naloxone. Ideally, they will even receive the naloxone itself while they're in the emergency department. Obviously, there can be issues with dispensing medications from the ED, but we've been able to create a system, at least at Dell and Seton, Maine, where the outpatient pharmacy can provide the naloxone in hand. Just every little gap there is, even if it's just from discharge to pharmacy, where the patient may have some issue where they don't receive the naloxone. Every little gap there presents a potential risk. And then, of course, they need to be educated on its use and when to use it and how to use it. I mentioned the direct referral to an OBOT, an outpatient-based opioid treatment. That is a pretty critical portion of their disposition as well. I think this is going to be a little bit dependent on what resources are in your individual community, but there's plenty of options as kind of listed here. At minimum, if a direct referral can't be made, at minimum, the patient should be provided with a phone number to one of these options to make an appointment. That is actually part of the legislation surrounding buprenorphine prescriptions from the ED. Patients should be counseled, of course, counseled about opioid use disorder, about buprenorphine, about naloxone, and about return precautions. And then finally, I think it's absolutely critical to be relying on whatever other resources you have in the ED, your social work, substance use navigators, peer recovery coaches to help these patients after they leave your care. So here's the algorithm once more, and happy to share this. But this last portion here in the disposition section, including the bridge therapy. The bridge therapy is dosed very similarly. Again, it's that same 8 milligram dose twice daily. That may be higher than what actually ends up being their maintenance dose. So it may be a fairly aggressive outpatient dose, but again, I think that the benefits of ensuring that the patient is not underdose, probably outweigh any risk from a more aggressive bridge therapy option. And then making sure that they have naloxone and education, and then that direct referral. And that's it. Those are my references here. And would love to take some questions, and if there's anyone with emergency medicine, I'd love to actually hear about any differences in your practice at your shop, or thoughts that you have. But thank you again for everybody for inviting me to do this, and happy to take some questions.
Thank you so much, Dr. Katona, for this wonderful presentation. While we open up the floor for questions and folks are thinking about the material you've presented, I will request a couple of our hub members who joined a bit later. So Dr. Weems, would you like to please introduce yourself?
Sure. John Weems, internal medicine, addiction medicine doc, and member of the hub team, and thankful to be a member of the Shout team along with Mitch, who recently joined with his leadership team at Seton, Maine. And I also have the honor of getting to care for a lot of patients who are now getting started on buprenorphine at Mitch's shop and coming over to our outpatient clinic. So Glad to be here and grateful to learn from you. Thanks so much for a great session.
Yeah. Thank you so much, Dr. Weems. And Dr. Ramesh.
Hey everyone, I'm Jan Ramesh. I'm a hospitalist at Dell Medical School. I'm part of the Shout team. Sorry, my video is not on. I'm having some internet issues, but happy to be here. Thanks, Mitch, for that great presentation.
Thank you so much. And with that, I'll open up the floor for any questions for Mitch. Questions or comments from our learning community.
It's Blair Walker. That was so great. Thank you so much for doing that lecture. I actually had a question for Dr. Weems just on that last note. What's your average range of buprenorphine dosing these days out in the clinics?
It's a great question. We were just talking about this, and I'd love to hear, Mitch, if you guys are seeing different stuff on the ED side too. So the modal dose, maintenance dose, so the most common one is 16 milligrams in the pre-fentanyl era. Because of fentanyl and fentanyl analogs increase potency, so there's higher degrees of physical dependence and tolerance. And we've seen here at our clinic, similar to other places across the country, that higher doses are necessary to meet people's, to both treat withdrawal and then to tamp down cravings once that people are at steady state. And so I think we're still 16 is the most common. More people are on 24 milligrams a day as a maintenance dose. And we were also discussing that in the initiation phase, right? So in that first day or two, people are starting buprenorphine. The most important thing is just to get stable on the med, and that might require more than 24. That might require more than 32. One of the advantages of the ER setting is assistance with medication administration. And so buprenorphine is a weird med that it's sublingual. The only way that medicine is getting in your system is through the blood vessels under your tongue. Once you swallow it, your stomach acid is really good at breaking it down. Your body is really bad at pulling any active medicine that gets into your bloodstream and actually works. So the sublingual administration, when people are having nausea and emesis, is really challenging in the setting of withdrawal. The other thing is often people do is they're using nicotine products, vaping or chain smoking cigarettes when they're in withdrawal. And those nicotine products are vasoconstrictors, so they close our blood vessels and they block the medicine from getting in. And people are, when they're starting buprenorphine in the outpatient setting, it's often time of instability and people have a lot going on and they're in distress. So taking the med as prescribed sublingually is a huge challenge, which means that often they're taking higher doses because less of each dose is getting in their system. So long answer to your question, and Mitch too, I'd love to hear your take on this. We are seeing higher doses for sure because of fentanyl increased potency. There are administration challenges and other reasons why higher doses on day 1 and day 2 are often necessary.
Yeah, thank you. That really is interesting, a point about the nicotine. I hadn't thought about that as being, potentially, modifying the necessary dose because of the decreased uptake. I guess I feel like the take home here is, again, just aggressive high dose treatment is really the best way to mitigate these patients' morbidity, mortality, and relapse risk. So yeah, it could be that the bridge therapy twice daily is maybe insufficient. Maybe it needs to be even higher. But yeah, I guess maybe the overall point is high dose treatment is superior, and you're far more likely, I guess, to undershoot.
I love that, Mitch. I have another question for you, and other folks working in ERs might be wondering, there's pressure to move, people need to get discharged, and while you guys have a really smooth looking workflow, how long does that take you? So what's the kind of time commitment for the model you're describing from the ER perspective?
Yeah, I mean, that's true. There is obviously a lot of pressure and constraints on things like length of stay, but I would say that, for whatever for whatever strain that's placed in terms of length of stay is probably made up for the fact that these patients, while they do have a lot of need for maybe reassessments and repeated medication administration, again, with opioid withdrawal syndrome and opioid overdose, these are all clinical diagnoses. We're not waiting on any labs to come back. There's no labs that need to be drawn prior to giving buprenorphine or making these diagnoses. So I guess maybe there's two sides to the coin here. Maybe this is a patient that appropriately, much like a patient with anaphylaxis that receives epinephrine, warrants a several-hour ED course, several reassessments, potentially second and third doses of medication, but they don't require any substantial workup or any workup typically. And so I don't think that they actually represent a tremendous strain on ED resources relative to other patients. And so hopefully that's not a limiting factor in them getting adequate care.
I see a question here in the chat from Susanna. We have so many smokers in our program. If they can't quit smoking, can we tell them to avoid smoking for maybe an hour after Suboxone administration? What do you recommend?
Great question. I'm glad we're talking about smoking. Our patients on opioid use disorder medicine, they get way better. They get their lives back. The functional improvements are very real. And so we get to turn our attention to other things that drive morbidity and mortality, like smoking. So I think smoking cessation is a great service to offer. There are FDA-approved medications for smoking cessation, including e-cigarettes. So there are vapes that are approved by the FDA that have been shown to help people who are addicted to combustible tobacco. It helps them get away from the thing that's driving all the cancer and probably driving a lot of the lung disease as well. So I think first and foremost, talk about meds and behavioral interventions that can really, really help get cigarettes out of people's life. Ask them what they're going to spend all that money on that they save from cigarettes, because cigarettes are just going to keep getting more expensive. The public health, public policy approach to deterring people from smoking. And then, so with that in mind, the specific administration recommendations we give in our clinic is to give yourself at least 15 minutes before dosing, if possible, away from nicotine that's either oral or inhaled, and then throughout the duration of the dose. Everybody has a different amount of time it takes them to get the bupe in their system. Typically 15 minutes is the longer side of that. So really a 30-minute window right before you're taking it, and then while the bupe is under your tongue is what you need. And then afterwards, the medicine that's gotten in is gotten in, and smoking further won't interrupt drug uptake. Hope that helps.
Thank you so much. And thank you, Dr. Walker, for sharing that list in the chat. With that, we will move on to the next part of our session. Thank you so much, Dr. Katona, again, for your wonderful presentation. And please keep the questions coming in the chat, and we can keep addressing them in the chat as well. And in the meanwhile, Taylor, if you could please share the program announcements from Be Well, Texas. Thank you so much. To claim CME credits, you must text by midnight tonight. Please text attend 100-959-05 to 844-502-1338. Next slide. Do you have a difficult case that you or your team have encountered? CSTAT offers you the opportunity to present any challenge your organization is encountering and receive feedback from our hub of experts and broader learning community. You don't have to prepare a formal presentation. We will provide a case form to assist with your case presentation. Please email us at shouttx@austin.utexas.edu. Next slide. I will request one of our colleagues from Be Well, Dante, to tell us a bit more about this study.
Hello, everyone. My name is Dante. I'm a research area specialist with Be Well, Texas. We've recently started up a completely virtual research study looking at the efficacy of a therapeutic app called Kios, which was designed to be used in conjunction with buprenorphine treatment for people diagnosed with opioid use disorder. We hope that the app can increase treatment retention and augment usual care by giving patients 24/7 access to personalized behavioral interventions. The study is 3 months long, it's completely virtual, and participants will, of course, be compensated for their time. If you have any questions, you can feel free to email our research coordinator there on the bottom of the slide, or give us a call at that phone number and we can answer any questions you have. As well, that QR code will link to an interest form if you want to pass that along to any of your patients. Thank you.
Thank you so much, Dante. Next slide, please. Join CSTAT for a session titled Thriving in Substance Use Disorder Delivery in Post-COVID Era, Telehealth for Behavioral Health Services. This will be on Wednesday, July 10th at 12 noon Central. And you can use the link that will be dropping in the chat to register for the session. Next slide. Our next Shout Echo session will be on Thursday, July 18th. Please to join us. And with that, we will move on to our case for today. Dr. Kapadia, you can take it away whenever you're ready. We can't hear you.
Are you able to hear me now?
Yes.
Okay,
Thank you.
sorry. So first, I just want to say thank you to Dr. Katona for a really great didactic session. Definitely learned a lot. And so I'm excited to be here today and share a case. So just to be very clear, my background is outpatient medicine. And so I feel like it's really important that from my perspective, they stay empathetic to what goes on in the hospital and what can affect discharges and dispose for patients. So I just want to be clear about that so that this is not a place of judgment as much as concerns that come up from inpatient that I should be mindful of on the outpatient side. So this particular case is not a patient that I saw, but I was discussing with a colleague of mine who works and leads our transitions of care efforts. And so that's where this case comes from, and limited information due to the special cyber attacks on Ascension. So I did my best to find the information, but I just want to let you all know. So the patient that we have here is a 44-year-old man who presented with right wrist soft skin and soft tissue infection, and this manifested as right wrist pain with purulent drainage. It was difficult to access the full HMP, but this is what I was able to gather. That was his main presentation, feeling ill from that. He had a history of injection drug use with both fentanyl and methamphetamine, a history of Hep C and tobacco use disorder. He wasn't on any home meds as far as I could find, and it didn't look like he was ever initiated on any medications for substance use disorders in the past. While he was in the hospital, looks like he received, appropriate antibiotic treatment with Vanc and cefepime, and then was continued on an oral dose of Bactrim. While he was being treated in the hospital, he was given hydromorphone IV, then changed to PO and methocarbamol for pain, as well as nicotine patches off with the tobacco use disorders. So looking more into his social history, he didn't report any support system. He has about 3 to 4 children, but unsure, not connected with them, has been experiencing homelessness for the past 20 years. And his way of getting transportation upon discharge to a skilled nursing facility, the SNF was providing transportation, but outside of that, he didn't have access to any, and he had been unemployed. His psych history also included PTSD, anxiety, and depression. And I'm sure this clinical picture is one that we see, unfortunately, all too often. So just briefly what happened in the hospital, it was as you would imagine, his micro came back with strep pyogenes and Enterobacter, with TOBA resistance that led to, what medications were chosen, both IV and PO. He did undergo IND in the hospital for appropriately for abscess management. Okay, so just a little bit more on his substance use history. He'd used cocaine in the past a couple times, really liked it, but didn't really have any current continued use of cocaine. Nicotine, he'd used half pack per day for 10 years. And, I just want to say, in general, I didn't see any information that he had been in any type of treatment in the past, whether inpatient, outpatient, or on medication therapy, received any substance use counseling. Alcohol, did not describe any history of alcohol use disorder. Had used cannabis in the past, a couple blunts per day. Last use was a couple months ago. He reported every now and then IV use of meth. And then let's see here, heroin and fentanyl, never much, but last use was about 2 months ago. But, given his presentation, I'm not sure, if over time more was shared about his use history, because as Dr. Katona mentioned, there's a lot of stigma around sharing substance use history. So this could have changed throughout the hospitalization, and we were just not aware of it in the documentation we found. And he likes alprazolam in terms of benzo use, but did not report regular use. So that was the clinical information about the patient that we found. And the question that I'm bringing to the team is, when I reviewed the documentation, and I think the first thing I was wondering was, the patient was prescribed Dilaudid. Why wasn't he started on Suboxone in the hospital? And at first I was like, maybe because of the spotty or unclear history of use. But then when I looked at the discharge summary, the concern was access to continued buprenorphine at discharge. And so the reason for not initiating bup was the concern about being able to continue use at discharge. And I've heard people ask that question. And of course, as you know, we have a really amazing SHOUT team at Dell Seton where this case had happened. And so I know there's a lot of education around it. So the question I wanted to bring to the team is, are there ever instances when people should be concerned about access to treatment outpatient? And my understanding is no, but I just, wanted to make sure I was thinking about, other perspectives that I may not be aware of. That's the main question that came out of here. And what would you advise this team in the future? And especially for me, knowing that this patient was going to a skilled nursing facility that we regularly discharged to. So that was, in combination, I thought, I would think this would feel like a pretty good dispo for the patient to be initiated on bup. So with that, I will, that is information about the case, and I will pass it on to our esteemed facilitators and leaders. And if there's any other questions about the case, I'm happy to try to answer those.
Thank you so much, Dr. Kapadia, for the wonderful presentation and bringing this case to share with us. I will open up the floor for any questions or comments from our learning community.
I'm sorry, this is Amy. I didn't catch the last part of that because a call came in, and I can't get my camera to come back on. But what is it that you're trying that's not working, or that you're trying to get with your patient?
Sure. So thank you for asking that question. I know it feels, the case in and of itself feels feels straightforward to me when I was thinking about it, but the question of a concern about continuity of prescription of buprenorphine that came up for the team, my question to our, this team here who does a lot of hospital-based treatments how would you, how would you address that? Like, how do we use this as a teaching moment or are there cases where you would be concerned about starting in the hospital because of, you're worried that they won't be able to be continued outpatient, or like what would you say to educate on that? Like that is my question for the team.
For the patient, correct?
For the team, it sounds like who missed an opportunity to get somebody on Suboxone that maybe would have done all the wonderful things that it can do to help people with opioid use disorder instead of, sending them out without treatment. So offline, I want to know who that was so I can go educate them myself. Because I would hope that it was somebody who just didn't know that our resources have really gotten so much better in this area. That sounds like the way I was trained in the same area 10 years ago, where we sort of felt like we can't get them to help, so we won't use it here. But that is sort of the way of the past. We really do have great clinics, both with, people who have insurance and people who don't have insurance. And the community care clinics, my understanding is you guys never turn people away, even if they have insurance, but they have no other option. Our pharmacies are well stocked with it, or sometimes we have to like wait a day to get all the strips we need. So they order them in the next morning and they come. But I think my main thing would say, no, we can help them. There's lots of resources in our community.
I want to piggyback on that. I'm sorry, Ms. Walker, I'll let you finish. I just wanted to.
Not at all. I was going to say, that may not be always the case in every rural community, but I'd also say, so what, still try and prescribe them as much as you can prescribe them and, and then do the best to kind of hook them up. We've got Be Well Texas, which is our statewide program that can help people as like the stopgap and really the, the thing that people can fall back on. So those would be my main ways to try to educate.
Just to kind of piggyback on that, it sounds to me like there's a lack of service coordination. In the sense that, we as a clinic make sure that we're coordinating with the larger Harris hospitals here in Houston when they get those emergency, particularly with pregnant women going in, inmates, people from the street. We coordinate with Houston Recovery Center, which is a RSS organization. So they're the people kind of boots on the ground. And they're in the emergency rooms, and then they're not just handing them a piece of paper with Texas Clinic's name on it or Durham. They're literally helping make those phone calls. So it sounds to me like service coordination. The moment you inducted that buprenorphine, somebody should have been on the phone finding a clinic that follows his insurance, has funding sources. What are the different ways in which we can take care of this person after you induct that Suboxone? So I would just say, as a team, more service coordination. Find out who's available, find out who has funding, what kind of funding, what Medicaids do they take, what Medicare do they take. I know certain people, I'm not going to call a certain clinic because they don't take commercial insurance, but I'm certainly going to call this particular clinic because I know for a fact they have a funding stream. So it's really about service coordination with your RSS folks or your social workers and within the hospital.
Thanks, Tanya. There was a good chat question, and it has been a barrier sometimes, is somebody who needs to go to a skilled nursing facility to recover, who can't go out to the community, and do they allow it there? Methadone often tends to be more of a problem than buprenorphine. But that may be different in different communities about skilled nursing facilities being comfortable with it or not. I don't know, has anyone else seen that or is continuing to see that in their community and still working on kind of connecting to SNFs that can manage?
Right before Jennifer goes, and I'll jump in on this. I'm in my third year as an RSS recovery coach, and I lived in my hometown for pretty much all my life, and I didn't even know that we had a methadone clinic. I had no idea that there was one in there. But when I started working here with this agency, they gave us, a resource book. They talked to us about what was available around here, and I was shocked because, as I mentioned, I've been here all my life and I didn't even know these things were around. They gave us a little bag with, like what's around, what clinics are there, who helps with what. And we got with our local tropical MHMR, and they had a resource booklet out that they update periodically. And so it really helped me, you know, put information together for myself, and I kept it with me so that when I know, oh, this person, you know, in the screening brought up, you know, well, they're going through some kind of MAT. Like, okay, I know to bring up this. I know how, you know, I have like extra pamphlets from different clinics around so that I can offer it to them, whether they're going to use it or not. I bring up the insurances. So from having absolutely no idea what was around and being given that, it might be, you know, like just get some packets together, and when something like that comes up, and just get the staff to know, you know, like, hey, when this is brought up, even before the treatment is begun, you know, like give them a packet, a little bag full of all the information that they'll need, so that, you know, they're informed. Because like I mentioned, I had no idea any of this was even in my hometown. So I was like, I was grateful to receive that packet. So just making sure that your staff has that information, and that they know that it's there.
Hi, Jennifer LaHue here, and we are in the Houston area. So any Harris County resident, we are a public facility. We will take patients and help them to qualify for eligibility. If we can't help them, we have partners with community linkages to help these patients. So if you need our information, I'd be very willing to send the electronic flyer to those who are in the Harris County, Houston area. Thank you.
Thank you, Jennifer. There's another comment here from Wendy. Another possible barrier was if the inpatient team was comfortable with inducting the patient on bupe, it would have been helpful to have an addiction team to consult.
Yeah, it's a good point. I think it's nice to have addiction consult teams at various hospitals. In this hospital, though, where this happened, it sounds like this was at Dell Eden, which is where our B team started, and where all the like hub members like me are present all the time. At least I'm there Monday through Friday, and have colleagues when I'm not there who do the same thing. So our psych team does a lot of addiction work, since we don't have a formal addiction team. But yeah, it sounds like I have a big fat question mark of I have no idea what the heck happened. I will say that one thing you didn't talk about was just we were in the middle of a cyber attack with no computer access, and I swear a lot of things fell off the wayside. You know, psychiatry consults went way down, and I think it was just because it was sort of a scramble. Everything took like 3 times longer to figure out, you know, what you were doing. So I wonder if it just, I don't know. I don't know what happened.
That's a really good point, because anytime there is a stressor on a system that's so big like that, you're struggling to do the basics of keeping people and their main hospital diagnoses in check, and that can allow other really important conditions to kind of filter. You know, the other thing that I just, you know, was thinking about too, and Dr. Weems did a didactics for family medicine earlier this week, and he talked about it, but just like that treatment of potential withdrawal and inpatient, even if they're not continued on it outpatient, the mortality of not treating that is so high at discharge that end of itself is a reasonable reason to start someone on it, which I think would be really helpful for you know, both inpatient and outpatient providers to keep in mind that even if you run out of the medication, you're still, you know, saving lives even with whatever amount of time someone's on bupe. And I think that was a really good take home point. I don't know, Dr. Winston didn't really summarize your teaching point very well, but that's what I took away.
I feel like every day a patient is on buprenorphine is a day that they're far less likely to overdose, see their mitral valve with a contaminated needle, etc. I don't think I would, like from the ED, not prescribe a bridge therapy if I was concerned that maybe they weren't going to make it to the maintenance phase. So maybe that is as much the teaching point as the awareness of what resources are available in this like very robust outpatient system we have, but just the fact that yeah, every additional day a patient's on buprenorphine, even if it's just that bridge therapy or that discharge prescription, is worthwhile. Think of the worst case scenario of not prescribing it is a fatal overdose on the first day of discharge. The worst case scenario, if running out of a bridge therapy buprenorphine prescription without appropriate follow-up, far less of a risk, I guess.
Thank you so much. This has been a wonderful discussion. Thank you again, Dr. Kapadia, for bringing this case. Dr. Weems, if you could please help summarize today's session.
Absolutely. Thanks, everybody. I think starting with our great didactic about ED-based treatment for opioid use disorder, some of the takeaways I had were keeping a high index of suspicion for opioid withdrawal syndrome and a very low threshold to initiate therapy, both to treat that withdrawal and then also to offer a bridge to ongoing treatment. I love that. Like every day on buprenorphine is a day where you're less likely to suffer morbidity and mortality related to opioid use disorder. And the other point was that, the acuity of people presenting with these conditions demands that clinical attention. And on the one hand, on the other hand, the resource commitment is not overly onerous. And so the ED-based work to get people on OUD is worth taking on. And then with the great case Dr. Kapadia brought, it really emphasized great opportunities for service coordination on the one hand, and it was great to hear folks from different parts of Texas sort of talking about, hey, get them over to us, we're talking with peers, we're working with Be Well, because we really are thankfully in a phase of change where the resource landscape is improving for our patients. And for those of us who have the privilege of working in federally qualified health centers, it is by federal law that payment cannot be a barrier. And so one resource is like always look for your FQHCs, and if they're doing OUD work, it's a great landing place. And then also what Dr. Walker brought up, that there's always opportunities for just-in-time teaching to sustain change efforts. So even at Dell Seton, where the B team was born, and where Blair Walker resides, somebody can sneak their way through the hospital and not get on buprenorphine. And it's a great reminder, right, that when there's competing pressures, like the downtime with the EMR, sometimes even really critical life-saving work doesn't get done. So we can always reach out to each other and to sustain those change efforts. That's what I took away. I think we got another minute. Anybody else with learning points they took away? You may want to unmute and add anything. Thanks everybody for joining today.
I just wanted to say, and it's because I feel very inspired by all of you, that, oftentimes I think what leads to hesitancy is like this, first do no harm, which I think is a really womp, like, why is that the first thing that's our goal in medicine, when it should be like, first do good by our patients. And this was like a reminder of like, being brave to do something, even if you're not feeling super equipped to do it.
Thank you so much. And thank you again, Dr. Weems, for the wonderful summary. And thank you all for joining today's ECHO and participating in the discussion today. As a reminder to earn CE credits, please text the activity code 1009-5905 to 844-502-1338 by midnight tonight. We also request you to complete the post-session survey using the link in the chat. The survey link will be open for 1 week. If you would like to present a case, please email shouttx@austin.utexas.edu. We look forward to seeing you at our next session on Thursday, July 18th. Have a wonderful rest of your day and enjoy your summer. Thank you.